Warning from an orthopedic doc on surgery. I want you to think about doing this instead. So in today's video, what I'm going to talk about is what maybe sometimes people don't really get out of a visit with an orthopedic doc is when do you really need surgery and when do you not need surgery? Okay, what other things are out there besides surgery to help you? Two, let's talk about regenerative medicine. I'm going to introduce this topic today. It may not be familiar to you, but I'm going to bring us up to speed. What does it mean? What do treatments like platelet therapy or PRP or stem cell therapy or treatment do for musculoskeletal orthopedic injuries? We're going to talk a lot about that in this video today, go a little bit deep on that so you have an understanding. And the 3 T's, I really want to get to this point because it's super important that you must seek out somebody that has these 3 T's. I'm going to get to what the 3 T's are, but I'm Dr. John Tate. I'm a non-surgical orthopedic doc focusing on regenerative medicine. And we're going to dive into this today because this is really what I do in my practice. I'm a non-surgical orthopedic doc. I want to help people have all the options and then also figure out when the best option is surgery, because just this week in my practice, we referred out half a dozen of my patients to see surgeons. So I'm not an anti-surgeon. Surgery is the best option sometimes. What you need to know is when is it the best option? So let's dive in. Check out this slide. This is showing some really bad looking knees. I mean, this is an end stage knee on screen here. And what I mean by end stage is the cartilage inside this person's knee is worn down to no space. So when people are told they have a bone on bone knee, we have to qualify, is that really true? There's 4 grades of arthritis. We'll get into that a little bit. 4 and beyond is really this end stage knee that we see on screen. One could look like a pretty normal x-ray, maybe some really early findings on that, but the patient could hurt a lot. So there aren't a perfect correlation with the x-ray findings and how somebody feels. We can have people that hurt a lot. I saw a woman with a knee so bad a few weeks ago, one knee, but her other knee looked exactly the same on x-ray, but she had no pain in it, okay? So the first thing to think about is the grade is important because we want to talk about when can we intercept the problem, and like any disease process, we want to catch it early. Early intervention is the key if we want to have the best chance of success with any treatment. So let's look at this slide here. This is showing a relatively normal looking knee joint. And what I mean by that is we're appreciating the space between the bones. This is where that cap of cartilage is on the bone and wears itself down over time. And then we get to, a knee on the other side of the screen here that looks pretty arthritic. So osteoarthritis, just so we iron out what that means, it really refers to the cap of cartilage on the end of the bone. People interchange that with something called osteoporosis, which is the strength of the bone, the density of the bone. Now, both are critically important to people as you age. We need to have good bone strength, but we need to have good retention of that cartilage, because for a lot of my patients who are middle-aged and older, what they don't want is surgical intervention. And so my job as a non-surgical orthopedic doc is to figure out if we have a solution there that hits the mark for them, can prolong that joint that they have longer, and maybe not need surgical intervention. So if we talk about the reasons why people get to needing joint replacement, it's because that cartilage space has gone to next to nothing. And beyond that, the angles of their knees have started to change. The range of motion they have become reduced, and the amount of pain they have go way up, and the functional aspect goes way down, meaning their life is getting really small because of the knee pain. So that's a situation where we got to appreciate what is going on and ideally intercept that before you're there. Because 2 patients this week, they're there. They needed to have joint replacement. That is going to be the best solution for the problem they have at that grade of arthritis. So let's revisit this path to regeneration, because our body innately does this for us daily, and million cells a second are turning over as I'm talking and you're watching. But our body has this process by which it self-repairs. This is controlled in our body by a lot of cells, including stem cells. Stem cells are the most powerful cell in the body for this action, that when the body gets injured and gets inflamed, we set off this chemical pathway and cascade of events in the body by which cells are brought in, cellular machinery to repair the tissue, regenerate that tissue, and if we give it enough time and space, then it can completely heal and we can get back to activity and on we go. Now, as we age in life, unfortunately, I'm already finding that out a little bit at 48, that our body takes a little bit more time and space to heal. It's not as resilient as it used to be. The bounce back factor that we had in our 20s isn't quite the same in our 40s. But we can still game the system by doing the right things in that time and space to help it heal. That's what I'm going to be talking about in this video. What are these things that we can intercept on this slide when you have an injury, that instead of blocking that inflammation, we can modulate the inflammation with some things. And I've mentioned these in other videos, but this is where we're using natural anti-inflammatory type compounds like curcumin, arnica, boswellia, topicals or ingested forms of these things that can help shut off inflammation in a healthy way, but not block the pathway by which the body heals. Then if we get to the regeneration and remodeling part of this, this is where we're going to go deep on this video today and talk about how we can accelerate repair in the body. Hey, why are pro athletes getting these treatments? That's a great question, because it gets them back faster. Like in spring training, there was an injury of a pitcher, got sent up to New York to get a PRP treatment in the shoulder. Of course, he had to shut it down for a period of time. Of course, he needed time to heal, but they wanted to strengthen that shoulder and get him back to high-level play faster. So it's an accelerant in some of these injuries, depending on what the injury is, to get people to that point faster. Because we all want to get better faster. So let's talk more about this. Because why you and your joints and my joints age, and why our body ages in general, is a depletion of multiple factors, but I'm going to pick on one today, and it's stem cell exhaustion. So if those stem cells are the most powerful thing we have in our body to heal, and we do deplete that as we age, so again, we're all born with an allotment of these cells. They're stored in our bone marrow and our fat tissue and circulating in our bloodstream. But over the course of life, through life events, a lot of choices, sometimes bad decisions, we utilize those stem cells faster. People that live a hard life by choice or sometimes not by choice, they can burn up these stem cells a lot faster. It's why you can see somebody who's 80 that looks much younger, and you can see somebody who's 40 that looks much older. I mean, just look at anybody that goes through political office and how fast they age over their time in office, right? So the churn rate on those stem cells is pretty dramatic. But stem cells have these unique abilities. As illustrated on this slide, they have the ability to replenish the cells as they die off. Because if we didn't have this mechanism, we would die pretty quickly. So 1 million cells a second, roughly, is what scientists think turnover in our body. If we look at the musculoskeletal system in our joints, every 5 to 7 years, we think there's a cycling out of almost all the cells being replenished by other cells. And as long as we're not pacing that aging faster than we can replenish, then that joint stays almost pristine. But of course it doesn't happen, so that is why we age. So we want to stack everything we can in our favor. 1, to retain good stores of stem cells. 2, to have stem cells that are really biologically active. So the healthier you are, the healthier that internal physiology in your body is, the healthier your stem cells are. And when I take stem cells from a patient to put them back into the environment that needs help, which we'll talk about a little bit today, if the body is really in a chaotic state, those stem cells are just going to get burned up even faster. So if we want max longevity in our treatments, I want to think about the physiology inside your body, and that's something that we focus on a lot here at Origin in my practice, to tune up the rest of the body while we're doing the treatment. So this slide shows what a stem cell can do. It's really got these 4 fates, we'll call it. Okay, it can self-renew, so every stem cell in our body can self-replicate a number of times before it eventually dies. It can differentiate, which means it can go to a tissue that needs help and differentiate into the tissue or the cell type that's needed to repair that tissue. So it's kind of the chameleon cell of the body when it's going out on patrol looking for damage, and then it can help that repair process in a multitude of tissues. And patients ask, well, how does that happen? Our body gives off these signals of distress that attracts the cells and teaches that cell or signals that cell what it needs to do to help this tissue that's injured. Pretty cool. Apoptosis means the cells eventually die, and there's a stage in between that some of these cells sit in that they're senescent. It means they're kind of dormant, and they can wake up over time and be utilized for this repair process. So just laying out some language today, mesenchymal autologous stem cells are what we talk about and what we take from a patient. There are other sources available that are from outside the patient that we can use to stimulate this action. But internally, we want to talk about this. Mesenchymal is pluripotent. It means those cells can differentiate. Autologous means it comes from you. So there's three sources of cells in your body. We're talking about stem cells. They can come from your bone marrow, and we can get a fraction actually from your fat tissue, which many patients love donating during these procedures because nobody minds donating their fat tissue. So there's caveats to all those treatments. There's caveats to who makes sense to take one tissue versus another. And that's where it's impossible to tell you what you need or if this even works for you. That's what we do internally in my office with patients. Really figure out, do these treatments make sense? What cell is utilized for the thing that they have, and design the best treatment possible. The third one that is not a stem cell is called a platelet. And platelets live in our bloodstream. So we have red cells, white cells, platelets. Inside of platelets, as we're going to talk about in a minute, there's a host of growth factors that we've all seen in action healing tissue if you've cut yourself. That's a platelet action that stimulates that healing. So think about a lot of this healing happening either from platelet activity, stem cell activity. It's just under the surface. You can't see it, can't appreciate it. But you can feel it in time if it works and if you heal. So this is the evolution of orthobiologics. This timeline will just frame out, back in 1997, these things came on the scene called hyaluronic acid injections. And they were actually, believe it or not, derived from rooster combs. How they figured it out, I don't know, can't remember the whole story on that, but there's a compound inside these rooster combs that contained, or this compound was contained in the rooster comb. And what that HA stands for is hyaluronic acid, and it's a lubricant in the joint. So we started using these in the 90s. And then you can see on the timeline, PRP came on the scene, 1999. What that stands for is platelet-rich plasma. This is where we draw one's blood, separate that fraction of platelets, and we can use those platelets, deliver back into the body at the site of the injury to stimulate healing. Pretty cool. 2000, I boxed that because that's actually where I started my medical training. And this is where cellular therapies really came online. So aspirating one's bone marrow, which is not a significantly uncomfortable thing to do with enough anesthetic, but we can take bone marrow out of somebody, out of the back of the hip bone, or the pelvic bone, ilium more correctly. And inside of that aspirate, we can get stem cells. Again, those powerhouses of repair and regeneration, that's where we can get them. So think of that as a bank of cells that you have that you can tap into, withdraw, and then deposit back where you need them. So again, the three banks again: bone marrow, fat tissue, platelets. And as things evolved over this timeline on this slide, what it shows is that we started to understand that these cells may have a multitude of other actions. And this one cell creating a new cell wasn't quite the action. It was one cell to many by releasing a bunch of growth factors, internal components inside those cells that were really stimulating the activity. And that's where things like this slide indicates exosomes. Exosomes are those internal growth factors of those cells. And this is where, in small spaces still available, there are cells that we can get from outside of a patient. Okay, this is live birth tissue, so we're not talking about embryos, we're not talking about aborted fetuses here, but today there's babies being born in your town. Some people like to keep the umbilical cord. If they don't, all that tissue typically goes to the medical waste. But inside that medical waste are potent stem cells, and inside those stem cells, growth factors. So the evolution of this stuff as it continues to move forward, because now what I'm showing you here is, well, 2014 is where this ends, but we're out to 2024 now. And what we're understanding is those cells, those birth tissue derived products, may have a multitude of benefits. And one, we don't have to extract cells from people through invasive procedures. Two, they may be way more powerful because they're younger than our aging cells. And three, they may be more widely available and somewhat scalable. So I think the future evolution that I hope to see is that we have greater access to those, and patients have greater access to those treatments if they need them. But all those things that I mentioned are available today in 2024. If you see the right person, wink, wink, that knows what they're doing and has access to the training and the techniques to do that. So let's jump into those three T's for a minute. Because when we talk about integrative orthopedic treatments, and I talked about PRP and stem cell and these other types, these what we call exosomes, the thing that's most critical is you find somebody with the training that actually does this stuff in their practice day in, day out, studies it, is deeply passionate about it, and will continue to evolve as you saw that evolution there. Some people are still doing treatments that are from the 1990s. They just haven't advanced with the evolution of this stuff. So you're getting very old technology And it doesn't surprise me when people come in and say, well, I tried X and it didn't work. And then I talk to them about how it was done. So again, the training of that individual. Second is the technology. Technology is advancing every year in this space. We got to keep pace with that if we want to give you the best treatment, which is what we're about here at Origin. Staying on that leading edge of these treatments and progressing with the evolution of the technology and the training. Like the third point is the technique. How do we deliver these cells back into you? So do you get one shot? Do you get multiple shots at multiple locations? Well, look, if you have a shoulder that's breaking down and you have multiple tendons in the shoulder, you have a small joint and a large joint in the shoulder, and you just put a shot in the joint somewhere, and we call that the spray and pray, that it goes everywhere it needs to go, it's probably not going to. And this is why somebody can fail these treatments, even though they're a very good candidate. Because again, the training, the technology, or the technique, those 3 T's, super important when you're picking the person you work with to have these type of treatments. Because look, these integrative, functional, we'll call them treatments, because this is the function of their body. It's based on the fact that every human body here, as this slide shows, actually has an incredible natural ability to heal itself. We just got to give it the right tools. So recapping a bit on stem cells here, how researchers believe now in 2024 time that stem cells repair joint damage in your body. Number one, it suppresses inflammation and pain as a result of that. 2, it releases positive chemistry, proteins or cytokines that slow down cartilage degeneration if we're talking about an aging joint like arthritis. 3, those cells, as you learn, differentiate to provide replacement cells, stimulate the environment to heal. And 4, if we give it the time and space and the right treatment, the tissue heals. Okay, it becomes less painful, more resilient, so you can get back to doing the things you like to do. So if we look at this, which is a very complex slide, it all comes down to these growth factors, the body's ability to release these growth factors properly at the right time and sequence healing. So all we're doing in regenerative medicine, there's a ton of complexity behind the scenes and within the chemistry of what your body's doing, but we're literally just resupplying the environment that needs more help with the actual cells that can provide it. The simplest way to look at it. We're just withdrawing from where we can take them from you, depositing them back where they need to go to resupply the area to heal. So running back through the treatments really quick, PRP, we know we can derive growth factors from these to stimulate healing. It's extracted from your arm through a standard blood draw. Again, cost can vary depending on where you are in the country, in the world. They're not covered by most insurance plans, not yet, maybe in the future. And that's the cost as you see. It could be $1,000 to $1,500, sometimes less, sometimes more. If we look at the fraction, again, this slide just shows that fraction of what we're getting out of a blood draw to get that PRP. Why are we getting those? For growth factors. That's going to stimulate the healing. You can see on this slide, again, there's some complexity here, but each one of these different types of growth factors has a different type of action in the tissue where we're placing it. So again, it depends on, and a lot of what we're factoring in these treatments is how concentrated these platelets need to be. What are we extracting away from the whole blood volume that could impair the healing or amplify the healing? So again, a lot of technique there, a lot of understanding that needs to happen around that case for you to have a successful outcome. And so let's look at some research. I always want to throw this in and pick some recent stuff because this is September 23. And if we look at this article and the title of it here, it says that PRP reduces the size of tear and partial thickness tears of the rotator cuff. So supraspinatus is the most commonly torn tendon in the shoulder. And this article said that compared to corticosteroid injections or cortisone, it had a much better effect for these people in the short term and the long term. And it makes sense. We're healing tissue rather than just shutting off pain, and cortisone has that degradation effect if we put too much of it in there. So again, degrading versus regenerating makes sense why this panned out to be a little bit more favorable for the patients that got PRP. As a patient was nice enough to share with me when I wrote an article about this, really had a lot of success with her husband for that treatment, and who was lingering in pain. Then he was living more in the present because he didn't have the shoulder pain. So win-win. This one talks a little bit about the HA-PRP combination. So this is something we do a lot in our practice. If we think about it conceptually, if we can put PRP in the joint, which is growth factors, and stimulate some repair, Then we can come over here and use HA, which can kind of protect the joint, lubricate it, and preserve that effect over a longer period of time. So a lot of these treatments are used synergistically in my practice. We can use the best of what's over here, potentially maybe still access through insurance. Some of the stuff here that maybe isn't, but will be in the future. We kind of combine those. And that's what they showed in this article, that there was a very good effect on knee arthritis with that combination. This article from the Mayo Clinic, November 2023, they were talking about thumb arthritis. So base of the thumb, very common joint that's affected that I see in my practice. People get cortisone, they try splints, they try therapy, but still joint aches and aches. What they showed in this study was pretty remarkable, that patients had, some of them, out to 18 months of benefit from a single treatment of PRP. So compared to steroids that may fizzle out at 6 weeks, these people are getting a long-term benefit from this treatment. And then it could be repeated, ideally over and over and over again, with not a detrimental effect to the joint, because unlike steroids, which are degenerative or catabolic, these are anabolic. They help rebuild and restore that joint. Different mechanism, longer lasting effect, way healthier for the joint if our goal is joint preservation. That takes us to MFAT. So MFAT stands for microfragment fat. And all that means is we're taking a fat harvest from a patient, from you, the patient, taking some of your fat tissue, and we're breaking that down through a process that we're regulated to do with minimal manipulation of that tissue, because there are rules around this stuff. We do have regulatory policy in the US that we must follow doing these treatments. But if we can take that fraction down, what we feel we get from that, or what scientists show we get from that, are some healing growth factors from that tissue. And there may be some stem cells in there as well that stimulate that action that we want. And this is an interesting article from Italy. So they were looking at this type of treatment, what we call a microfragmented adipose tissue treatment for people with knee OA. And what they showed, or knee arthritis, 68% of these patients 4 years out were still reporting good benefit from that treatment. And this is January 2024. And they're studying this in this group of patients for another 4 years to see what is the long-term data. But I can tell you that if a treatment of any other type worked this well, that 70% of patients had a single treatment and it lasted 4 years, I mean, it'd be a multi-billion-dollar drug, which is maybe directionally where this stuff is heading. But this is just showing that there's a lot of science to support this. And some practitioners out there just maybe aren't studying the science. They're not aware of the science. It's not their specialty or their area of expertise. This is what I do day in, day out in my practice, keeping pace with the current literature, keeping pace with the current technology and the evolution of it, so that we're delivering the best treatments we can for patients. So let's close this out on this, which is autologous stem cell. And this is where we're taking, again, that ileum supplied bone marrow aspirate. And now what we think we can get is probably the most powerful growth factors we can take from a patient from those stem cells. And we can use those to treat harder tissues like that articular cartilage, as this diagram is showing, inside the joint. And so it can stimulate that self-repair process. Now, if somebody's got a complete void of cartilage, there's some limits to what these treatments can do. And I'm honest with my patients when we're in the consult room and we talk about this, that, I mean, if the cartilage is completely gone, like true bone on bone, no cartilage left, their joints angled, they've lost range of motion, they might be able to get some pain relief potentially out of the treatment, but it's not going to straighten their knee again and give them all the motion back. So the goal is we really want to capture people before they get to that stage, intervene, use these type of treatments to slow down that aging. And again, this just shows another study here, February of 2024. This combination of PRP and bone marrow and HA outperforming corticosteroids for pain and function scores for patients getting these treatments. So again, the science is there, pretty robust. And again, when we look at the safety profile of this stuff, it's there. We look at the trade-offs of cortisone injections over and over. We know where that goes for people. It just degrades the joint faster. So the next frontier, as I mentioned, could be these stem cell derived growth factors from birth tissues. There's a lot of study going on in this space. We're excited about it because I think it's, one, a resource that is otherwise being discarded daily across the US, that if we have the right mechanisms and we can get enough science around this stuff, we can really understand the mechanism for, one, how it works, two, who it works for the best, three, how to scale this stuff up safely, the cost of these treatments can really come down for patients in time, which is exciting. I think for anybody that needs it, for us providing it, opens up the access for these treatments. So again, I'm going to recap what we learned today. The simple path to healing and regeneration in the body. We have an innate process that does this for us day in, day out without fail. Million cells a second. Your joint turns over every 5 to 7 years if we want to look at it that way. When the body's inflamed, we want to modulate that inflammation with things that are more natural, that don't block the machinery of how your body is going to work down this path and heal. Then, how can we get over here and accelerate that regeneration so that the body can repair more effectively to get towards complete healing? And the final slide, which I'll mention, is what it looks like for people that get these treatments. I mean, it's up and down. I mean, there are good days and bad days, but the body takes 6 to 8 weeks to really respond to a lot of these treatments. So it's not an overnight success. People got to be patient with the process. They're doing some work alongside this with physical therapy, typically working on nutrition and other principles there to get them the best stack of things around the treatment to get their best effect. So we can take somebody in my practice from hurting, some of them for decades, as this slide shows, from hurting to healing in a matter of months. People walk in that have knee pain for 10 years. I saw a guy have 20 years of knee pain. In a matter of 2 to 3 months, he could be better, right? Less pain, better function, better all the way around for him. So that's the takeaway today. If you're hurting, we have great treatments to stimulate the body and nudge it towards healing. You absolutely have to find the people that have those 3 T's. They have the training, they have the right technology, meaning current, up-to-date, evolving with the technology, and they have the right techniques that they're injecting you with rigorous protocols, hopefully developed over a lot of cases and experience to know what works best where. We're part of an organization, an affiliate group of docs across the country that study this stuff, work at it, and continue to evolve our protocols as we get more and more information. So, recapping on this slide, this is all the stuff we can treat now with this. Think about joints, ligaments, tendon injuries, if they're partial rotator cuff tears or knee arthritis, huge thing that we see in our practice. These are really good treatment options for people to look at. Again, the data is robust, the science is there, the literature is there to support the safety and effectiveness of it. You just have to have the right person to sit with you, analyze your situation, look at the imaging, look at the data, examine you, and figure out if these treatments may make sense. So, as Noelle shared in this nice testimonial she did for us, look, she was skeptical. A lot of patients out there are. If somebody said, hey, they're going to take blood and shoot it in your knee and they're going to make you better, you'd probably tell them they're crazy. But it's not crazy. From what you learned today, you understand the mechanisms now by which the body heals. You know what platelets are and stem cells and how they work to have this action. We're simply just resupplying your body where it's been asking for help for a long time. And like Noelle, she was skeptical. Over the first few weeks, I'm not sure if this is working, but look what she says here. By 6 to 8 weeks, hey, it takes some time to work. But she went from a weak, shuffling old woman, is how she felt at 59, back to her active and sassy self. So she's stronger. She's noticed that her body feels physically just that, stronger, more capable, not a liability for her. So, when she weighed the cost of doing a treatment, maybe that isn't covered by her insurance for the benefit she got, she had an amazing return on her investment. And she was talking about losing her livelihood, her ability to work, because all the other treatments she tried had really failed her. All the conventional things that she worked through, from NSAIDs to steroids to other procedural work to physical therapy, none of it really got her across the finish line that she needed to go back to work, to go back to activity and recreation as she wanted to. So thankfully we met and we were able to deliver this type of treatment to her, and she had a fantastic benefit from it. So in closing, that is the crux of this, right? If you're facing these other treatments or you've already worked through these treatments, I implore you to look at these. You got to find the right person that's qualified to look at the case, from examining your imaging to look at you personally in a clinic and examine you, and then figure out if these treatments are right for you. So hopefully this information connected with you in some way. If you liked it, please click like. If you'd like to see more content like this, please subscribe to the channel as we continue to build this out. If you have comments about what I shared today, drop them below. We'll answer as many as we can. I have a great team that works with me internally here in the clinic, and they're in the comments often answering questions for people. If you want to go a step deeper than that and talk to somebody on my team, also in the notes below, you'll see a link where you can click over and fill out a short form and get on a phone call with somebody in my office. We call it a discovery call. We just want to open up the case with you, see if we can help you in any way, because that's what we do here at Origin.